Okay, so then I would like to actually introduce our first speaker for today, Captain Jeffrey Coady. Captain Coady is a commissioned officer in the U.S. Public Health Service and a board-certified clinical psychologist. Since 2011, he has served as the Region 5 Administrator for the Substance Abuse and Mental Health Services Administration, or SAMHSA, an operating division in the U.S. Department of Health and Human Services. He provides strategic consultation to national and regional healthcare stakeholders on policy, financing, and innovations to advance behavioral health prevention, treatment, and recovery. And Captain Coady has received numerous professional, military, and civic honors throughout his career, so I could go on, but I'm going to stop there so we can give Captain Coady plenty of time to talk. So please join me in welcoming Captain Coady. He's going to pull him up for you. Just good.
Good morning, folks. First of all, I want to thank our host at SSA here and the SHARE program. I know that putting together conferences is a time-consuming event. They do just happen, so thank you. As well as everyone who took their time to come here. What I'm going to talk a lot in terms of is what sort of happens at, they say, the 30,000-foot level, what's happening in our region, but everything is local at the end of the day. And you know, whether you're working in a clinic or whether you're sort of supervising a system or something, really all healthcare is local. So what I might talk about might have relative to your job, but also might be different depending upon where you're at. So I just want to respect that there might be some differences in terms of your experience. I have a ridiculous amount of slides in a very short period of time, so I will go very fast through my slides. I'm sure we're going to send them out. And also, you know, I know we have a wonderful panel of speakers, so we're going to go into detail about some of the other information that I'm probably going to glance over in my slides. But I'm happy to answer any questions and hopefully provide a bit of a framework for our conversation. And speaking along frameworks, I was very happy Dr. Thompson had mentioned that she is not an expert in addictions. Full disclosure, I'm not an expert in geriatrics either. But that's kind of the point of why something like this is so important, is we are converging our different disciplines together. I think, when I start thinking about recovery and I start thinking about prevention and what people need, it's about us working together as a team and connecting the dots. So I think that's something that really excited me about this opportunity, is we can bring these different stakeholder groups together to be able to talk about some of the challenges that individuals and communities are facing. And the second aspect I want to mention, although this conversation is specific about opioids, there's sort of this cluster of things that we really have to kind of think about. And that has to do with addictions, pain, and mental illness. I mean, that really is the frame of which we're talking about. The drugs will change over time. They're changing now. We know the stimulants in terms of increasing in many of our communities. But unless we sort of look holistically at how these different kind of components work together, some of the other factors, risk factors and environmental factors that are influencing a person's life, some of the disparities, we're not going to get to the solution. So I just want us to kind of keep that frame as we kind of go through at least my part of the presentation. So some of the questions that I'm going to try to answer are up here in terms of providing a background of how we got to where we did. What do you know about addictions? Because I think it's important to talk about the science. Who was impacted by the opioid crisis, or at least who we maybe initially thought who was impacted? What are some of the solutions? Let's talk a little bit about recovery. And then, I think recovery on the back end is also social determinants on the front end, so we're going to talk about that for a second. What are some resources to implement these solutions? And then, what have we not discussed? So, it's very important to note that in terms of the number of individuals who have opioid use disorders, about 2.1 million, and of that 2.1 million, 1/5 receive treatment. Okay, so obviously there's a lot of opportunity in there in terms of the number of people that receive treatment, which to me speaks to screening, assessment, as well as referral treatment, as well as building our capacity. But the other part on that is that only 37% of those people who receive treatment, so 1/3 of the 1/5, actually get medication-assisted treatment. So opportunities for implementing evidence-based treatment, that's some areas we've got to work on. And so when we talk about opioids, I know many times folks say we're in sort of the third wave or maybe even the fourth wave in terms of at least the overall drug sort of crisis that we're sort of having. So many times prescription drugs were sort of the initial sort of focus that we had. And then we know as we sort of looked at reducing sort of the consumption as well as some of the prescribing patterns of prescription drugs, folks moved then to the illicit drugs, they moved to heroin. Some communities, they might have started at heroin. We want to recognize that. And now from the heroin, it's becoming adulterated with fentanyl. In some communities, there's not even heroin, it's purely fentanyl. I was just in St. Louis this last week, and we don't have heroin, we just have fentanyl. And then some other communities are now, that's not our problem. It might be meth, it might be cocaine or something. We're sort of going to the stimulants now. And then sort of, some folks are sort of mixing them together. I believe the term is called goofballs now in terms of what we're sort of hearing some of the individuals referring to as the mixing both the opioids and the stimulants. But specific to the older adult population, I think some of the data that we have is, and I think this is really important, that older adults are prescribed and use more medications than any other age group. So obviously, when we start talking about prescribing, the older adults can be significantly impacted. And I think as we sort of initially sort of focus the conversation on the crisis, we're really looking at, who are the most likely individuals who are overdosing? And I think the older adults, that conversation really wasn't incorporated, I think, in terms of much of our task force that we were sort of seeing develop. And I think our areas and agency were involved to maybe some limited extent. So we, really didn't hear the voice, I think, as much in terms of some of the specific crisis response aspects of what we were doing. And we also know in terms of the older adults, in terms of looking at our Medicare Part D data, I think that almost 90,000 were at serious risk of addiction due to prescribing high amounts of opioids. So when we began talking about the risk factors, we began talking about, co-prescribing naloxone, in terms of where are we able to sort of disseminate, who are those folks at risk for overdosing? And, how does this data that we have, which are all going to be local at the end of the day, help influence what actions we should be having? Something that pointed out to me really specific on this slide had to do with suicide. I mentioned sort of looking at this as a cluster where opiate-involved suicides have doubled among older adults since 1999. And as well as that emergency department have increased 121%. So again, it speaks to both some of the impact, but as well as some of the opportunity I believe that we have in terms of where we can engage older adults. So if we're looking at some of the data, and I think it's consistent with what you showed previously, we're looking at some of the age groups in terms of overdose deaths. I really think we start to see the 45 to 54, the 55 to 64, some really significant increases. So I think that's really what's helped driving this conversation today. But also makes me think, all right, before we get to 45 to 54, what's happening then in terms of where some of these seeds or some of the roots for this might be happening? Where are some of the trauma and some of the other unmet needs that might be happening further upstream that we might be missing in terms of interventions? So I think it's just something to frame about, just doesn't, boom, the switch doesn't turn usually at 45 to 54. What happens before then that might be setting the stage for this? And then we sort of look again at another sort of data at the prevalence of non-medical prescription opioid use in adults. And again, we continue to see the increases over time. And I think across all of the different sort of age groups, 50 plus all the way up in terms of 65 plus. So again, in terms of the prescriptions we're looking at, the non-medical use. So that's sort of the frame that we're in terms of the prescribing as well as some of the other factors. Now, something I think is really important when we talk about this is to talk about addiction. We somehow jump to opioids and we kind of miss this conversation about addiction sometimes. And I think we make a presumption that, many of us are in the field, we live this on a daily basis. But obviously friends, family, individuals, they don't. So when we talk about the opioid crisis, it's an opportunity for us to talk about addiction. And some of my slide decks, I have this slide of sort of the egg, hey, this is your brain on drugs, and that's where we were, many years ago. But now we know how the science has advanced, and, we can see the imaging pattern of the brain in terms of people who have addictions and what that looks like. So I think it's important that when we have this conversation, we start talking about, dopamine. We start talking about how addictions impact the brain. Because this really is going to get to the heart of what addictions used to be as a moral failure, as opposed to, hey, this is, an impact on the brain in terms of how it functions, in terms of our drive, in terms of our memory, in terms of our executive functioning, and our ability to stop. We often heard the conversation, well, despite the negative aspects, why didn't the person stop? Well, isn't that sort of one of the diagnostic criteria for addictions? So we got to make sure that we talk about the science and we have this conversation with other people. And they begin to understand, the equation in terms of how the science and in terms of what happens with the brain, that ability to stop, depending upon where they are in their addiction, it's not a choice. The person does not have that choice, be it smoking, alcohol, or opioids, all three of which we have medications for, by the way. And I wonder how many people know that there is medications for all three of these particular addictions that we can have. So who is impacted by the opioid crisis? I think initially we really sort of were focused on those individuals, and appropriately so, in terms of who were overdosing. But then we started to say, well, what about the children? Because obviously many of them had children. So we started to see the children. Then it's like, well, okay, oftentimes who's going to raise these children? It's going to be their parents. It's going to be the older adults. And then we started to hear more, I think, sort of stories in terms of the prescription drugs and how they were diverted, how sometimes the opportunity for older adults, to be mistreated, and in terms of some of the adult protective services we're hearing in terms of how the opioid crisis was impacting them in their homes. So it really is the lifespan of individuals that are affected by the opioid crisis. And it's not just the healthcare system. I think that speaks to the convergence. It's going to be our child welfare. It's going to be our adult protective services. It's going to be our labor. It's going to be our school systems. It's going to be community at the end of the day. So when we come together to talk about the impact on older adults, think about who else needs to be at the table. Right now, we have everybody's attention. It's a rarity if you've been in the behavioral health field to have people's attention. When you call a meeting, people are coming. This is a great example. So we have to use that as an opportunity really to pull our communities together, to begin looking across the lifespan, both promoting prevention, treatment, and recovery. So we looked at some of the risk factors in terms of sort of older adults, and we did see, the female gender. I think you had sort of mentioned in terms of your data locally that started to stabilize a little bit in terms of looking in terms of the older males, in terms of the impact on them as well. And that's something we're seeing in the community here in Chicago. Social isolation, we know that's a risk factor, obviously for folks in recovery and, in terms of folks developing potential for addiction. And obviously, history of SUD or MI, some of the other sort of classical things that we sort of look at risk factors in individuals' lives. But, it's important that we sort of pay attention to that. And then also in terms of comorbidities and co-occurring illnesses. Oftentimes when we have the multiple medications in older adults, obviously in terms of, having some other chronic illnesses, how does this all sort of weave and intersect together? And I think that really speaks in terms of our attempts to try to train the workforce, our primary care, our specialty care, in beginning to understand how all these different pieces fit together. That's why we need the team together, the treatment team, our community together, to understand how these components work. So here is, I put this slide on here. I often don't put sort of symptoms down on slides, but I thought this is really important because I think it speaks to some of these missed opportunities and perhaps even some of the bias we might have. I remember in terms of, not that long ago, in terms of the field of behavioral health, where oftentimes someone with serious mental illness, they were smoking. Oh, it's okay. They have SMI. They can smoke. It's okay. And then we all know the data, that individuals with SMI were dying 25 years younger than their peers. Well, why was that? It wasn't because of the serious mental illness. It's because we weren't taking care of the rest of their chronic health conditions. That kind of led to behavioral health primary care integration. A great effort. Look at the whole person holistically. I think this sort of says, I think we can learn from that in terms of SUD, in terms of, how is it that we can really look and not necessarily attribute to, maybe it's dementia. Oh, they're older. It's okay. Sort of not recognizing the fact, hey, we still need to intervene and to treat people. I think it just really speaks to us in terms of how we might be seeing clients and not necessarily really looking at some of our own implicit biases in some of this. And I also recognize it's difficult. It's difficult sometimes to make these sort of clinical distinctions. So I think that's how we build our competencies and use some of the available resources out there and grow the workforce, that we're all going to be better together and feel more empowered too as a workforce. All right, so we laid out the problems, right? Or the opportunities, depending upon how we're going to view this. So in terms of what are the solutions? So HHS has a 5-point strategy looking globally at the opioid crisis. One is better data. Historically, we have not had the best data. But a lot of money is sort of going to our states. We had mentioned Super being here, both our Department of Health and other entities where we're really trying to increase the data, whether it's the ER visits, which I know CDC just published some information yesterday that some of our states have seen a decrease in ER visits attributed to opioids. Very encouraging news. But I think we need better data because we have limited resources, so how do we allocate those limited resources? And that's why where you are, wherever you sit, whether it's the emergency room in your neighborhood, whether it is the nursing homes, wherever the facilities might be, they're going to have the best data, as well as you will too. So it's that local data that's really important. We can roll this up and do the national data, but the local data is equally as important. Better pain treatment. I mentioned we can't talk about this unless we talk about the cluster in terms of pain. And I think pain, I want to say it's both emotional pain as well as physical pain. How do we distinguish between what pain is and treat that appropriately? Because we also know that symptoms oftentimes could be depression or something. Are we giving pain for something different? It might be depression. So how are we sort of identifying what is the source of pain? Addiction prevention, treatment, recovery service. I'll talk more about that. That's kind of our bailiwick, although we're involved in all that, ours being SAMHSA. Overdose reversals. I know we're going to talk about naloxone. I have a presentation later, but in terms of the importance of naloxone, I think we're seeing great success in communities that have really flooded naloxone. And we'll talk about that. And then better research. And this is more, I think, sort of the NIH's, the NIDA's, really sort of digging into the research base. How we're going to look at all this together that have sort of the resources and with our academic partners to look at the research component. So I want to briefly sort of mention naloxone, and we're going to talk about it more later. But, I know we talk about the importance of, I think we did a great job of getting naloxone, which is a life-saving drug in terms of opioid reversal. Did a great job of getting naloxone into the hands of our first responders, the EMS, the fire, the police. But many times, my friends in harm reduction will say the first responders are the individuals themselves and the individuals who are using drugs. I think that's really an opportunity that we can have. And I think many sort of task force and efforts, we bring together people in recovery, which is essential, absolutely essential. But we also want to look in terms of bringing people who are actively using. How do we tap those networks for those people who are using and their friends so that we have naloxone available? And our Surgeon General put out an advisory about naloxone in terms of some of the different groups that are at highest risk. Individuals leaving jail, individuals leaving treatment, individuals who are prescribed high amounts of opioids. And we know that includes the aging population. But I also want to remind folks that I had mentioned sort of the shift in terms of the drugs, that we're getting to more stimulants, cocaine and meth. And much of that is often, like I said, mixed with fentanyl. So if you have a client, individual who is using stimulants, there's a good high likelihood they're using opioids as well, either knowingly or unknowingly. Make sure they have naloxone. So I think it's really important in terms of getting that into the hands of people, older adults and other individuals. So there's a lot of strategies to address the opioid epidemic, and thankfully our states have been given, bipartisan fashion, have been given funds to state opioid response grants. And I know then through those grants, then many of them have come to the local level. And that's where I think it's an opportunity to be at the table. I think it's an opportunity for aging community or aging stakeholders to be at the table, to be helping to inform, what is the plan? To be the voice of your stakeholders so that some of the efforts, what you're engaging in and some of the opportunities that you're there to help be part of that plan and bring that voice. I think some of the specific areas we talked about, our community prevention, sort of looking at, what our task force is doing, what our strategies, the crisis services, working with police and law enforcement, diverting people, making sure they get to the right appropriate treatment, working with our ERs, inducing medication-assisted treatment, warm handoffs, recovery coaches being involved in the ERs, then our clinical practice. And I think we get to some of the CDC pain management guidelines, which I know have been a source in terms of the aging population has been very concerned about that. And I think sometimes the way things go, the pendulum swings, and it swings from one direction to another. So I think, the intent was obviously to look at, are we prescribing opioids appropriately? And to whom? And to what amount? And for what duration? However, recognize at the same time we have to seek that balance, recognizing that for opioids and for people in different sort of stages, and there's a palliative care and so on and so forth, this is a necessity. So how do we seek that balance? And I think that's really important for us as clinicians to help understand, who is opioids appropriate for and for what time, for what duration, like I had mentioned. But we want to really train our workforce to help understand this. But then I'd also talked a little bit about screening and assessment. We don't just jump to medication-assisted treatment. I mean, like any other condition, we have to screen. So are we doing screening SBIRT, screening brief intervention referral to treatment? Are we using motivational interviewing? Are we talking about this in our clinical actions? And then from there, what's the assessment? Are people dependent? Are they addicted? What is the best set of course of action and working as a treatment team together, the prescribers, everybody, in terms of what we can do for this individual. And then making sure they have the appropriate pace of treatment. Might be outpatient, might be inpatient. I don't know, but looking at our continuum of care. But that's really, I think, sort of the area that is really an opportunity, in particular with the aging population, we can focus on is some of this clinical practice. And I don't want to forget recovery support. Recovery, our recovery coalitions, our recovery environments, are they aging friendly? There's many individuals who have successfully recovered and growing old. So how is it in terms of some of our housing entities, in terms of older adults? How is it in terms of some of our other places where older adults convene that it's recovery friendly? And I think it's a question we always should ask in terms of our stakeholders. How are they promoting recovery for older adults? And then we get into a little bit more in terms of, I think, sort of the workforce, like I had mentioned a little bit. And obviously, I think our state and our local partners are doing a great job in terms of trying to increase, I think, data weight physicians. And that's those physicians, nurse practitioners, and PAs who can prescribe medication-assisted treatment. And how do we really do that in our graduate training programs upstream, so individuals are fully prepared when they do enter the workforce that this is eventually going to be a chronic health condition, much like we saw with HIV and AIDS. That's where we're headed. And I'm very, very happy in terms of the opportunity where we're moving that direction. So I want to speak a little bit about MAT because I think it's talked about so much but misunderstood as well. So I think what we're sort of seeing is, there's three types of medication-assisted treatment. There's naltrexone, methadone, and buprenorphine. Which is the best? Whichever works for that individual. I think that, we sort of have this pejorative term sometimes, well, you could be on this one or not that one or this or that. I don't know. I mean, that's between the individual and their doctor. So what we are trying to encourage is that we're in a position that individuals have access to all three medications. And that's going to depend on a lot of different factors in terms of their physiology, in terms of, are they pregnant, et cetera, et cetera. So I think our ability to really promote MAT is important, but it's not a standalone. We often know with addictions that, it is not only obviously in terms of a chronic disease, in terms of the brain, but there's also those other wraparound services that we have to have. And I think the importance of understanding and promoting the wraparound services is critical. But then one of the challenges we have in the field is some of the myths about MAT. It's substituting one drug for another. Do they know that, with MAT, that, you don't get the euphoria with MAT? That's kind of the point, that you get the stabilization that allows people, in terms of withdrawal symptoms and the craving, that allows them to get into treatment. If we can stabilize that in terms of the brain, let it heal for a period of time, we can engage in, obviously, much of the recovery management, contingency management sort of efforts that are going to promote recovery. So the more we are consistent as a field with our messaging, the more people can have clarity. And I think it's an important conversation that we want to be clear on in terms of, in particular, with the opioids. So I talked about team. I talked about community coming together, but also in terms of our clinical teams coming together. I was fortunate where in my career I sort of started off in terms of working on HIV and AIDS. And I came into a clinical team right away. That was the only thing I knew as a professional. We had substance use disorder counselor, psychologist, chaplain, infectious disease, primary care, preventionist, case manager. I mean, there was like 10 people. It was great. And I'm like, wow, doesn't everybody practice this way? Then I realized, no, not everybody, but also it's resource dependent. I get that too. But we're doing a great job. And the fact that everyone's here today works in different settings, That's where we have to be. And that team care is what people need because it reflects people's needs. And it gives all these different perspectives. I think our panel today reflects those different perspectives and how we see individuals and the resources and levers we have. So, think broadly in terms of who that team is going to be. Is legal on that team? Many of our clients have legal challenges. Where are some of the opportunities for that team to grow? The more complex the crisis is, the more that team has to grow. It's a complete relationship between the two variables. And one of the things that we want to recognize is that team has to be trained on trauma-informed care. Trauma is both the risk factor for addictions as well as, something that happens with individuals who have addictions. So the importance that all the team members are trained on trauma-informed care, and we do change that conversation from what's wrong with you to what happened to you. If our team starts with that conversation, we're going to go down a path that's going to be much more empowering, exploratory, and really get the outcomes that we need. So I think the importance of having the trauma-informed care is something that I can't emphasize enough, because when I start talking about those seeds that might be sort of planted earlier in life, go way back to childhood, we want to talk about ACEs or something, maybe they are, something that we need to be addressing further upstream. Otherwise, we stay in crisis mode. We continue to stay in crisis mode. So we got to dig out of that. So recovery-oriented system of care. So I know our state's moving ahead in terms of Illinois, in terms of recovery-oriented systems of care, as many different sort of states throughout our region. And I'm really excited about that. And I know I've got the 5-minute sign. So because I think that what we're seeing in terms of like this treatment team, what we're seeing in terms of other people talking about social determinants of health, it is the recognition that the whole person needs to be treated. And when you're on the front end, in terms of maybe you don't have housing, you don't have supportive employment, you don't have connections to community, we call it social determinants of health. But then when you're on over here, we call it recovery. It's the same elements. So is there some space for our recovery community to be talking to our public health folks about what is, social determinants of health recovery? What's the language that we're both using? Because the recovery field knows better than anybody else the importance of social determinants of health and connectedness. So it's an opportunity for us to be at the table and to grow our recovery-oriented systems of care while improving social determinants of health, while making communities more resilient. We're advocating for the same things, we're speaking a different language. But there's those tables that we can be at collectively together. And it's incumbent upon us in terms of what we do as professionals and for our clients. This is going to make our job easier too. So here's just sort of a symbol in terms of recovery-oriented systems of care and some of the elements that would be included in it. It's a holistic look at a person and the factors beyond sort of that clinical setting in terms of us getting broader in terms of the family community and many of those anchors in our community. So how do we implement those solutions? Two things I want to talk about real quickly. One, SAMHSA grants. SAMHSA gives two types of grants. One is a grant to the state in the form of a block grant. And then the state will often has a state plan in terms of how they're trying to utilize those monies. And they have an advisory board at the state. Some of you might be on the advisory board for either the substance use block grant or the mental health block grant. It's a great opportunity to have your voice heard. Secondarily, we do discretionary grants. So those are competitive grants. And those grants can be given to many different communities. So the community, depending upon what you're trying to advance, and I put some of our open SAMHSA grants right now, encourage you to apply. We have great grants out there, really, I think, to help move systems ahead. So I encourage folks to sign up for samhsa.gov, get our updates. And I also want to recognize my fellow partners in HHS and across the federal government have grants to address the opioid crisis. It is not just SAMHSA. So look broadly, depending upon what you're focused on. The other lever that we have that I'm really excited about is our technical assistance. SAMHSA has training and technical assistance centers. And traditionally, you had to get a SAMHSA grant to get training in TA. Whether you have a SAMHSA grant or not, you can apply for and seek out SAMHSA training technical assistance. Whether it is in prevention, whether it is in mental health, whether it is in addictions. This is something that you can utilize. I know it could be anything in terms of trying to advance medication-assisted treatment, promoting ESPER, trauma-informed care, suicide prevention. Wherever you want to go, they will have resources and materials and perhaps something more intensive depending upon the type of system change you're trying to make. It's a free resource. Highly encourage you to reach out and to take advantage of it. So I know we're going to have questions later. I know my time is up. But here were some of the questions that I was sort of looking at in terms of, trying to help promote convergence, both in terms of the aging population in the behavioral health field, trying to advance convergence in terms of addictions and mental health, and where are those opportunities that we can be working more closely together. So I appreciate your time. I'm looking forward to hearing our other speakers, and look forward to talking later.
Hi, my name is Adam Scheffler. I'm a social worker here in Chicago. In patient safety, we have the National Patient Safety Reports that are sort of charting progress over like the last 5 to 10 years. Is there do you know of any way that we can get a sort of a global look at how all of these prevention and treatment programs are actually reducing harm and reducing deaths or whatever? I mean, I know it's kind of a general question, but we've got all these programs. So do we have a global metric we can look at and say, this is what we're getting when we spend this amount of money for this kind of evidence-based treatment or whatever, sort of not only here, but globally? I mean, we're in a global society, and these problems, some of them originate outside our borders as well. So.
I'm not familiar with the report that you had indicated. I'm not familiar with that. But in terms of looking at the return on investment, let's say, in terms of, what is the impact of opioids from labor to obviously looking holistically, our justice system, all the different partners. There's a lot of data that looks at the impact from, years' lives lost to the cost. And then I think now folks, what they're trying to do is sort of help make the argument, or how much does, treatment costing us and what are we getting in return? So I think there's different states that are sort of looking at that in terms of, we've invested a lot of money in terms of the opioid crisis. And that's really a focus in terms of what are we paying for, what are we getting? I think insurance companies are absolutely looking at that as well. I think they have some pretty good data on that as well. But I can't think of a specific report that I can point to that really looks at, okay, we spent this much money and here are the results. I think it's a little more compartmentalized right now. But I think it's certainly something that states are thinking through. I was just in, like I said, St. Louis, and they had presented on, for example, their data on how much is a treatment episode costing in terms of their efforts. And although treatment episodes were down in terms of cost, people were in treatment longer too. So while we're spending more money, what is the societal benefit? So how do we factor all that, I think, sort of cost avoidance in there? They could just put one emergency room visit in there, and they're probably going to have their data show their success. But I think they're trying to get the hands on the multiple data sources to be able to make that argument. But I agree. It's an important policy argument that we need to make in terms of the cost spent.
Hi. Within the context of the elements of informed consent, I am wondering how the education is being presented to patients to use these drugs, what the options and benefits and risks are, not only of the use of that drug, but also in how that drug is stored, how it's monitored when people come in to visit. In other words, you're talking about older adults who will be perhaps visited by children, grandchildren, those within the age groups that you discussed, and how they are being told to store those drugs, how to dispose of them, how to do what they can to not only take care of themselves, but also to minimize the options of having those drugs end up in the hands of other people who are also impacted by the opioid crisis as it's presenting itself today.
No, I appreciate your question. I was just talking to the doctor here. I'm gonna punt that question to her in terms of her presentation. I think she's gonna cover that. I will just say, I think the messaging is getting out there, but it's gonna be implemented provider specific at the end of the day. I'll give you a great example. Like my mom, my dad had surgery. My mom would not let him take any opioids, and my dad was in quite a bit of pain. Maybe it was appropriate. I don't know. But I think in terms of having that conversation, probably would have been helpful, I think, in terms of her and the physician at that time, because she watches the news and thinks worst case scenario. So I think having that individual conversation, I think we're going to address that a little bit later, is something that is emerging, if you will, in terms of the fidelity. I can't speak to that, but it's a great question.
Sound like it's happening.
Probably in pockets.
And I think I'll take it a step further than that. You've also got to think about the implications that can arise out of different elements for litigation. I don't want to think of informed consent within the context of what I'm trying to raise as a malpractice deterrent so much as a treatment enhancement. Mm-hmm. But it's also true that you've got litigation lawyers who are watching this stuff so carefully, and they're going to be looking for parents, other people who bring in and say, oh, this happened when so-and-so went to visit such and such, and this was readily available, and it wasn't protected, it wasn't put away. And you've got a whole level of litigation that could be coming out and attaching itself to parties who are innocent. It's very important, I think, within the context of something like this, that you've got to think past and into all of the social contexts where this kind of abuse can find its way that will be detrimental to society and all the things that we're trying to do.
Thank you.
Great. Thank you for your comments. If you have other questions, just maybe keep them in your mind or write them down so we can keep us on schedule, and we'll have a chance again to ask our whole panel the questions next. So let's give Captain Coady one more round of applause.